Hello, I'm Noha Shagabi. I'm with the Neuroengineering and Pain Research Lab at the University of Connecticut under the supervision of Dr. Bin Feng. In this video, I'm going to be talking about opioids. Opioid analgesics are pain relief medication, and they are the most prescribed class of medication in the US. In 2014, 245 million prescriptions for opioid pain relievers were dispensed in the United States. 65% of that was for short-term therapy, which is ideally less than 3 weeks. However, 9.6 to 11.5 million prescriptions were for long-term therapy. Now, opioids can rapidly relieve many types of acute pain and improve function, but their benefits when prescribed for chronic pain are much more questionable. They are improperly used, and their widespread use has resulted in a national epidemic of opioid overdose deaths and addictions. 37% of the 44,000 drug overdose deaths that were reported in 2013 were attributed to pharmaceutical opioids, and in 2014, opioid addiction affected approximately 2.5 million adults. So how do opioids work? They work by binding to what is known as mu-opioid receptors. Mu-opioid receptors are mainly concentrated in three regions. The first is the brain regions that regulate pain reception, which explains the analgesic or pain relieving effect of opioids. The second region where mu-opioid receptors are concentrated is in brain reward regions that govern the perception of pleasure and well-being. This explains why opioid medications can produce euphoria. The third region is the mu-opioid receptors in the brainstem. They are mainly responsible for the respiratory depression associated with opioid overdose incidents and deaths. Since opioids activate pain-relieving regions and reward regions at the same time, taking opioids can cause a learned association between receipt of the drug and the effect of the drug. Over time, this learned association can lead to a strong desire, almost a craving for the drug's effect, analgesic or pleasurable. So what's wrong with that? Well, for one thing, it can cause tolerance, physical dependence, or even addiction. Let's take a look at the difference between these three. Tolerance is developed through the repeated administration of opioids. It's like the body gets used to it and they become less effective, so the patient needs a higher drug dose to feel the same pain relief. But then that keeps happening and you need to keep increasing the dose till you can end up with 10 times the original dose. The problem is that increasing the dose to maintain analgesia increases the risk of life-threatening overdose. How so? Well, we said there were three regions activated by opioids, not just the pain relief and pleasure regions, but also the respiratory depression region. The respiratory depression region does not develop tolerance as quickly as the other two, so a drug dose that has little analgesic and euphoric effect can have a significant effect on respiratory depression. Increasing the drug dose can thus cause too much respiratory depression, and the region hasn't developed the same level of tolerance and can in turn be life-threatening. Sudden discontinuation of opioids can cause what is known as withdrawal symptoms. These symptoms include headaches, chills, insomnia, diarrhea, nausea, vomiting, and muscle aches. Physical dependence is what is responsible for the occurrence of these symptoms. It's like the body is so used to the opioids, it's struggling without them. These symptoms can vary in severity from barely noticeable to very uncomfortable. Recovery from physical dependence can take from 1 to 14 days, depending on the type, dose, and duration of the opioid prescribed. The occurrence of these symptoms can be prevented or reduced by dose tapering, which is gradual reduction of the drug dose over a prolonged period of time rather than suddenly stopping the drug altogether. In some patients, the repeated use of opioids can also lead to hyperalgesia, which is a state of increased pain sensitivity. This can lead patients to inappropriately increased opioid doses, which only makes the problem worse. In case of hyperalgesia, dose tapering is the better strategy. Lastly, addiction. Thankfully, it's not as common as tolerance and physical dependence. It occurs in a small percentage of patients taking opioids. It develops slowly, usually after months of exposure, but it becomes a separate, often chronic illness that will need more than simple opioid discontinuation. If not properly treated, there's a high risk of relapse for years after. There's basically no way to know the exact dose or the duration of opioid administration that will lead to addiction, as the risk varies substantially among people. However, because their brains are still developing, adolescents are at a higher risk of addiction, so careful consideration is needed when prescribing opioids to adolescents. Features of addiction include a pronounced craving for the drug, obsessive thinking about the drug, compulsive drug taking, and lack of control when trying to stop. These behavioral changes are associated with actual structural and functional changes in the circuits of the brain, including the reward, inhibitory, and emotional circuits. In a person with an opioid addiction, they can reverse the effects of tolerance and physical dependence in 1 to 14 days after they stop the opioids. But the changes that are associated with addiction will take months or even years to get rid of after stopping. There is a very high risk of overdose in addicted patients after discontinuation of opioids. Their intense need to take the drug is still there, but the tolerance that previously protected them from overdosing is not. So if in a moment of weakness they relapse and take the dose they were once used to, it could lead to an overdose. During the past 15 years in the United States, the rate of death from opioid overdose has quadrupled, and non-fatal opioid overdoses that require medical care have increased by a factor of 6. All these risks are present to some degree with all opioids and with all pain diagnoses, so avoiding a particular type of opioid or by prescribing opioids to a particular type of patient will not help. However, there are common strategies that can help reduce the risk, including limiting the prescribed opioid to the lowest effective dose for the shortest effective time, regular monitoring and reassessment of patients to allow for the tapering and discontinuation for patients who are not receiving a clear benefit or who might have an increased risk of overdose. Some characteristics of those who might have an increased risk of overdose include those with history of overdose or with a history of addiction to any substance. Those with health problems associated with respiratory depression or if they are taking medication that has a depressive effect on the respiratory system are also at risk. Also those with liver or kidney problems, since their body won't be able to effectively clear out the drugs from their system, leading to longer lasting drug levels in their blood. Also history of suicidal thoughts or attempts or depression, because some cases of overdose may be purposeful suicide attempts. One big problem is drug diversion, which is the transfer of opioids by patients who have been prescribed opioids to family members or friends. This type of diversion is best managed by educating patients on the dangers of sharing their medications and on the importance of safe storage and disposal. In conclusion, we'd like to point out that although addiction is a serious chronic condition, recovery is a common result of comprehensive continuing care and monitoring. The use of medication-assisted therapy in managing opioid addiction among patients with pain significantly improves outcome. However, we can't possibly simply continue previous practices with respect to the management of chronic pain. The associated risk of opioid diversion, overdose, and addiction demand change, and in the next video we'll discuss future and alternative methods to manage chronic pain. Thank you so much for listening, and I hope this video was useful to you.